So here we are in mid-pandemic, and there's just beginning to be recognition of this condition that I would, as a medic, call it post-COVID syndrome, perhaps. The patients, the sufferers, are calling, and some are calling it long hauling, or calling themselves long haulers. And that terminology is catching on because it's catchy. So there is, what I'm going to do is draw information from many and diverse sources, because that's what we're having to do at the moment, of course, because it's such a rapidly evolving condition. And some of these sources are quite unconventional. But first of all, some definitions. Let's say, because this is not yet formalized, but this is what, these are the definitions we used in the BMJ article that has been quite widely accepted now. We suggested that acute COVID is 0 to 3 weeks. Post-acute would be weeks 3 to 12. And then chronic COVID would be over 12 weeks. What we do know is that patients with after COVID, about 10% are experiencing symptoms still in that post-acute period, 3 to 12 weeks. And probably 1 to 2% are experiencing symptoms after 12 weeks. So that's 1% of them all, 3 to 12 weeks. And if we just put that in perspective, I think we're arriving at a case fatality rate of about 1%. So the rate of long COVID, well, actually, I should say that the terminology long COVID is everything from 3 weeks on. So it's that the medics might subdivide into 3 to 12 weeks and then over 12 weeks, but long COVID is all of that. Okay, so case fatality rate of 1%, over 12 weeks, about 1 to 2%, 3 to 12 weeks, 10%. Multiple different sources arriving at those same sorts of figures, so I think they're good. Talking of multiple sources, so to find out about the symptoms being experienced, there is a publication based on Facebook members of from the Netherlands and Belgium, members of a group still experiencing COVID-related symptoms, and also patients joining the Lung Foundation of the Netherlands. And amongst these patients, and these have not been hospitalized. The top 2 symptoms by far are fatigue and dyspnea. And in this group of obviously quite selected post-COVID patients, because they're interested enough to join this group, 90% are describing fatigue and 70% dyspnea. About a third to a quarter are describing headache, persisting headache, fever up to 37.9, chest pains, palpitations, tachycardia. They know they've got a tachycardia because they're all measuring themselves, aren't they, with self-tracking devices. So those are the most common symptoms. If you're uncomfortable with using Facebook as a source of your data and your information and your medical education, then I can offer you a proper, very good study actually, based in Bristol in the UK, where they took 163 patients who had been hospitalized with COVID and followed them up at an 8-week point and a 12-week point. Well, they started with 163, 110 made it to the 12-week follow-up point. Some deaths, some confined to care homes, some just unable to attend the outpatient appointments. But on those 110 patients, there are really detailed assessments, including chest x-ray, oxygen saturations, 1 minute sit to stand test to see if they desaturate. And they choose that method because it's socially distanceable in a hospital environment, because things like the 40-step test begin to be a bit difficult when we're all supposed to be keeping our distance. Spirometry and a very detailed quality of life and function questionnaire called the SF36. And so amongst these post-hospitalized patients, again, top 2 symptoms, fatigue and breathlessness, but also lots of chest pain, arthralgia, myalgia, anosmia still in some. And the other thing that was apparent from this study was there was very little difference between patients in the prevalence of them that had symptoms according to their severity of illness in hospital. So most of the patients in this study were in the moderate severity category, where they required oxygen, but were bad enough to be hospitalized, and a small proportion were requiring ITU or non-invasive ventilation. And the pattern was very similar across these groups, slightly less frequent in the ones that didn't require oxygen, and more frequent in the ones that got admitted to ITU. But at least, 60% or so of the patients that didn't even need oxygen had a lot of these symptoms afterwards at the 8 and 12-week point. And the implications are considerable for us, really, as GPs. One of the things we're having to grapple with is that not all these patients will have a formal diagnosis of COVID. Certainly in the UK, there wasn't much testing going on in March and April. And of course, with the existing PCR tests that we have in the UK, the false negative rate of 20% is still very much a thing. If you try instead to use antibody tests, well, some patients do not seroconvert. And we know this because they can be PCR positive with classic line. And then some patients in the UK heeded the self-isolation advice, self-managed, stayed at home, and avoided testing out of consideration. This was before we could get postal tests. So we've got a big chunk of patients who, from the timing and the symptoms, we believe have COVID, but we can't confirm it in the conventional way with our tests. Are we to disbelieve them? I don't think so. I think we have to, take the balance of probability that they too have had COVID, and if they're presenting with symptoms now, that they have the post-COVID syndrome, as it were. So what we do know about these symptoms from multiple data sources now is that the severity of the symptoms in that post-COVID period bears little relation to the severity of the acute illness. This is especially true of the non-pulmonary symptoms. We know that these symptoms are relapsing and remitting in 80% of the patients, that sometimes those relapses are unpredictable, but very often they're precipitated by exertion or by cognitive or stress. The symptoms affect every possible body system. So respiratory, shortness of breath, cough, chest tightness. People talk of lung burn, severe sinus congestion, sore throat, hoarseness. Cardiac, palpitations, high heart rate. Chest pain is in there, but if you think the chest pain is related to cardiac pathology, then on the whole, you're not dismissing it as the post-COVID syndrome, you're investigating it a little further. Neurological, headache, pain anywhere, paresthesia, crawling, electric shocks, sensations, vibrating, insomnia, cognitive difficulties, brain fog is the common phrase used over here. Still change or loss in smell or taste, sensory overload, a bit like the autistic patients complain of, gastrointestinal symptoms, nausea, diarrhea, acid reflux, decreased appetite, abdominal pain, musculoskeletal, severe muscle aches, tightness or weakness, and of course fatigue. And we don't know what system to attribute the fatigue to. Of course, it could be more than one. Quite a lot of the specialists in the field think it's neurological in origin. Weeks or months down the line, you will get muscle deconditioning as well. And sometimes you get exacerbation of metabolic conditions that could contribute to fatigue, poorly controlled diabetes, for instance. When we're talking about fatigue, this is not average tiredness. It's not fatigue that improves after a good night's sleep. It's disabling fatigue. So I'm moving on to aspects of this that work without you being able to see the presentation. So what might be the mechanisms?
Excuse me, we had someone that said she could show the presentation. So should we give it a try just for 30 seconds and see if it works?
How clever. Okay. You tell me when it's showing.
And it was Marta Kisiel. If you could try and share it.
Hello. Yes, please. I'm Marta Kisiel. I'm
hello, Marta.
Environment and occupational science, and I do some research on post-COVID.
Right.
Very interesting. So I can try to share your presentation.
Sure, go for it. If you manage to, go to slide number 9. That's where we've got to.
Can you send me, Magnus?
Okay, send me your. Have you sent me your email or?
Yes, I did in the message. Marta Kisiel, gmail.com.
Okay.
Just while you're trying to do that, I have to just say that it shouldn't be me talking to you. It should be you talking to us. We are in awe of Sweden in the UK. You know, your approach, your consistency, we seem to be going about things in a way that will ensure we have a lot of experience of long COVID.
Yeah, I got it. Let's see.
I can just say that we had in the spring, we had a webinar similar to this, and we had some presentations about partly the clinical stuff and some research comparing to SARS and MERS and so. But there wasn't so much science, and so it's very good that we have this follow-up now to see if we're any smarter at the moment.
Yeah, I'm going to share it soon. So,
oh, well done. Yeah, so flash through to about number, what did I say? Yes.
The numbers right now, so please tell me.
Okay, right. Can you go on to the next one? Okay, so this is just to show that common sense, there's still a place for common sense, okay? So this has been created by Matthew Knight, who's a respiratory physician locally, who's running a rehab clinic for post-hospitalized patients. He's already processed 1,500 patients. He's got masses of experience. And what he's shown here is that if you look at the lower severity of patients, the percentage down at the bottom, the self-managed at home, a lower percentage of them will have protracted symptoms. It all looks very symmetrical and a little bit contrived, but actually if you compare it with all the data that's coming out, it really works very nicely. So, you know, of patients who needed oxygen on the ward, 50 to 75% of them have symptoms after discharge and, you know, way down the line. But it still seems to be true that the severity of the symptoms isn't proportional to the severity of the original illness, which is very odd. Right, can we have the next slide, please? Thank you. So, mechanisms, what is going on? So I like Anthony Fauci's description. We have no idea what is going on at the cellular level. Do you know Anthony Fauci? He's the notorious, infamous, but also highly trusted professor of infectious diseases in the States. He's heads up the US pandemic strategy, such as it is. He's often at loggerheads with our friend mutually exclusive. So the post-exertional fatigue is very reminiscent of ME, chronic fatigue syndrome, which is obvious to all of us. So there's a feeling maybe there's a kind of central nervous system sensitization going on, as we think might be going on in that disorder. Perhaps it's a vasculitis. Well, there seems to be vasculitis some of the time, hence the bizarre skin rashes and COVID toe. Perhaps it's an endothelial disorder throughout the body. And there's a beautiful paper, if you'd like to look it up, by Libby and colleagues, hypothesizing that in the end, it's an endothelial problem. And that beautifully explains all the microthrombosis and the thromboembolism and the alveolitis in the lungs and the serositis causing the pleural effusion and the pericardial effusion. And of course, who gets what is going to, in some way, relate to our genetic predisposition and our polymorphisms. And actually, Anthony Fauci also suggested the state of immune activation, by which he means, you know, perhaps when you're stressed or you're exhausted or your immune system works in a different way to when you're well. Anyway, we don't know, and it might be a mix of all of them. Next slide, please.
We have a chat question.
Oh, okay.
What is COVID toe?
Ha! Have you not got that phrase? Ha!
No.
So this is the funniest thing. My husband was on Facebook and he said, so what's this COVID toe then? Lots of these people seem to have COVID toe. And I said, oh, for God's sake, don't be ridiculous. You know, that's Facebook rubbish. And you know, you listen to anything and you read anything. Anyway, the next day in the British Medical Journal was the description of COVID toe. And it's very like chilblains or frost nip. It's a sort of purpura at the tip of the toes, and it's thought to be due to a vasculitis. And it happened in the middle of summer in these patients. It's bizarre. But they described it first on Facebook and, you know, doubting medics like me denied its existence. So how are we going about finding some answers? Well, in the UK, we've got something called the FOSS COVID study, aiming to recruit 10,000 patients after hospitalization, but to recruit a good range and to study in a detailed way for 1 year. And within that context to develop a platform for developing individualized care strategies. You know, what kind of patients need this, what kind of patients need that, what works the best. I like this statement: we cannot fight what we do not measure. This comes from a professor of public health in Southampton, Dr. Alwan, Prof. Alwan. She's had COVID, she's got long COVID, and she's quite vociferous. And she's banging the drum for acknowledging it exists. Is that okay? She's banging the drum for acknowledging this exists, beginning to record it. And I wonder how many of us GPs are taking the trouble to code this disorder. There is a SNOMED code for prolonged illness after COVID, something like that, because, you know, in time, our data will be the substrate for research. Next slide, please. So just to show you, I have called upon a little bit of the emerging literature about post-COVID. In my earlier presentation that you haven't seen, there was some data from a smartphone study going on in the UK. It's called the COVID symptom study, and it's got, I think it's 4 million people have logged onto it. It's prospectively collected, and it's asking you to record your symptoms every day and record whether you develop COVID and if you have the test and what does it show. And from this, they've got 3,650 people with COVID symptoms who are also PCR positive. And so satisfying, and PCR positive within a few days of the symptoms. So pretty well satisfying most medics' definition of acute COVID. So 3,650, and amongst them, they've made a lot of detailed observations, and that's one of the sources of the 1 to 2% post 12 weeks, 10% 3 to 12 weeks. I've become interested in a long COVID support group, and it's, do you know, I've put Facebook, it's Twitter, I'm sorry, it's a Twitter group, and they have no less than 25,000 members to create, and it's quite interesting because they're quite rigorous. If you look at what they've asked for, they've said, you know, only join if you've had the experience of long COVID. They don't want any conspiracy theorists, anti-vaxxers, anti-maskers, pseudoscience. They want no party politics, no business promotion, no selling, you know, snake oil. They want people to share their experience, but not tell others what to do. And you can follow it. You just can't join it if you're a medic without the condition. And it's proving quite a good resource. Next slide, please. So one of the things that strikes us as GPs is, who do we need to worry about? Who do we need to do anything different with? So Matthew Knight, this rehab specialist and respiratory physician, reckons anyone with persistent symptoms at 12 weeks, so that 1 to 2%, he thinks should be referred to a dedicated rehab facility with access to consultants who can then evaluate if there is a specific organ disorder. He says predominantly these patients have fatigue. A few of them will have measurable organ damage. Also, at any point, if patients develop severe symptoms and a severe deterioration, may need specialist assessment. Anyone with persisting hypoxia that wasn't pre-existing, or over 4% desaturation on an exertional test, could have persisting pulmonary pathology. There's concern that maybe some of these ARDSs will develop into pulmonary fibrosis. And if you do some investigation that worry you, very high D-dimer, that might mean a PE, very high natriuretic peptides that might indicate heart failure. You're going to want to take it further, not just say, don't worry, you'll get better, it's post-COVID. Next slide, please. So on the cardiac side, I've helped put together an editorial because I thought that as GPs, we kept hearing about what was going on in hospital, but I haven't been told anything about the implications for us. So for instance, we know that between 12 and 36% of patients admitted with COVID have acute myocardial injury as defined by a rise and a fall in troponin. And amongst that group, quite a big group, the pathology is quite heterogeneous. So some patients are having a traditional type 1. Some are having type 2, which is where you've got demand perfusion mismatch, perhaps due to hypoxia. Others have non-ischemic causes, so myocarditis, a classic viral myocarditis, or Takotsubo, which is so-called broken heart disease, the stress cardiomyopathy, where the heart just dilates massively. If they survive it, the acute phase, they do fine in the end, which is true of myocarditis on the whole. And then various sort of cardiogenic shock type phenomena precipitated by sepsis, often, or cytokine storm, or sometimes right ventricular strain due to pulmonary embolism. So all of this can cause an acute rise and fall of troponin. Any of these conditions can have sequelae, short-term, subacute, and chronic. And we don't know how many are going to hit us. There was a rather scary paper produced by a German author called Puntmann, and she studied 100 patients, only a third of whom had been hospitalized, but all of whom were thought to have COVID. And she did cardiac MRI at 1 to 2 months after the acute illness. And she found 78 abnormal cardiac MRIs. This created a Twitter storm, I can tell you, because the implication was that this many patients could go on to have long-term cardiac sequelae. In fact, smaller studies have replicated her findings, but importantly, all those patients with abnormal cardiac MRIs were not symptomatic at that point. They had normal troponin, normal biomarkers, normal natriuretic peptides. So we don't know what the significance of that abnormal cardiac MRI is. And I'm reminded of a oncologist who once said to my academic mentor, Prof. Trisha Greenhalg, never biopsy a hot node, it'll scare the hell out of you. So he was talking about never biopsy someone with an infected node. You're going to think all hell is breaking loose, and just don't do it. You'll be diagnosing cancers and God knows what. Let them get over the infection before you think about biopsying a persistent node. And this sort of reeks of this to me. I mean, these patients have been very ill recently. Their cardiac MRI is normal, but calm down, the body may repair it, we hope, but we don't know. So it behoves us as GPs to not only acknowledge these patients with protracted symptoms, but also have our antennae out for could this be actually a developing heart failure situation? It's asking a lot of us, isn't it? Next slide, please. And this is just a reminder that, because I know not all GPs know this, that after confirmed myocarditis, athletes should not be allowed to train intensively for 3 to 6 months because of an elevated incidence of sudden cardiac death due to arrhythmias. So I'm certainly seeing patients who discharge with the diagnosis of myocarditis, I haven't seen an athlete yet. I've seen some enthusiastic exercisers, and, you know, I'm just asking them to please not go back to intensive exercise, at least for 3 months. And if anything is abnormal at the time of discharge from hospital, I'm saying don't exercise intensively until all of those findings have normalized, be it your echo or your natriuretic peptide. And this is strange advice for us as GPs, because we're always promoting exercise, aren't we? Next slide, please. I think, oh yeah, the only one I want to pick up from this in the interest of time is flu jabs, because it's obviously flu jab season. So the Matthew Knight's advice is don't give them a flu jab in acute COVID. I guess that makes sense. And probably not in the post-acute phase in the first 3 months, just in case it stirs up, you know, immune reactions. Next slide, please. So what therapies are available? It's really important that we acknowledge...
I just want to say that shut off the microphone. Someone has it on, I think. So okay. Please continue.
Okay. We need to acknowledge this condition. I'm afraid there's a lot on Twitter and this long COVID group in particular about GPs just saying, yeah, it's nothing, you know. Also, that's how the patients perceive it. And I think we have a sort of cognitive bias, don't we? If we don't understand something and we feel like we haven't much to offer, we really want to move on to something we can do something with. Or maybe this is just me, but we have to watch out for that tendency and, you know, just say to the patients, yes, it exists. What can we offer? Cognitive approaches are helpful. So people can develop harmful mindsets. You know, this means I will be ill forever and my husband's going to leave me and my children will grow up to be drug addicts. You know, nip that in the bud, take it back to where are we now? Try and help them move their minds off excessive preoccupation with their physical symptoms, distraction, mindfulness. The fatigue management is really interesting. So the OT person who's listening will know there's so much more about this than me, but energy conservation techniques are key. So the analogy our physios use over here is they say, imagine a jug of energy and imagine a teacup. So normally you have a jug of energy. Post-COVID, you have a little tiny teacup. At the beginning of the day, think, what have I got to do? How am I going to spread my little teacup of energy? Prioritize, plan it. What is just not important? What am I going to need help for? Because it is important and it's going to exceed me. And this will stop people cleaning the kitchen and then having nothing left for the rest of the day and some other really important things like picking up the kids. Chunking, you divide a job into little bits and you do a bit, rest, do a bit, rest. This can enable you to complete a job. Exercise, this is where we got into trouble with the ME chronic fatigue syndrome group. I think it was called the PACE trial, was very, very badly received by ME and chronic fatigue sufferers. And it was basically promoting rather blunderbuss, I think they called it graduated exercise. And it wasn't really sensitive to people's recovery rates. And the problem with these syndromes is that you can make somebody so much worse by overexerting them. And it can be emotional or cognitive exertion as well as physical. Any of these things can cause a sort of rebound, the boom and bust, loss, and really hold them back. So this pacing is absolutely key and a really sensitive exercise program. And one of the sort of aphorisms is always leave 30% in the tank. So don't exert yourself to the point where you've got nothing left. because that tends to be counterproductive the day after and the day after that. Looking at Facebook isn't always good and restful. And bearing in mind that cognitive is activity. So it's really interesting, this, because a lot of these patients do say, sometimes I just have to stare at the wall and just not think about anything. Healthy diet, find some fun. So fun recharges the battery. Sounds like the sort of thing your mum would say, but Professor Tim Pito is a professor of infectious diseases. He's a mega brain, and he's been looking after chronic fatigue and worldwide nasty Ebola, you name it. And he is convinced that fun recharges the battery, and I think I am too. We need to support our patients with phased return to work, and it's a long period, 8 to 12 weeks minimum, not 1, 2, 3 weeks like we're perhaps accustomed to. We've got a website, I'm sure you can look at it. It's quite good, actually, for patients, but maybe Sweden's got something better. Next slide, please. So this is just a sample of long COVID on Twitter. I do recommend following it. So the first slide, just the first little screenshot just shows how what they're promoting is the second talks about how too many people have reported their GPs have denied their symptoms, and that in itself causes distress. The next one is the conundrum that this patient's evidently, her GP acknowledges that she has the condition, but isn't allowed to refer her because she didn't have a positive COVID test. That's just rubbish, isn't it? There's another COVID group here called Long COVID SOS, and they're shouting that we are going to need more consultants and physios working in this field. And a shout out that the NHS is just beginning to recognise this. And this is true that NICE, our national body, National Institute of, God, what is it? Something and excellence, isn't it? Anyway, they're the source of evidence-based recommendations. They're putting together recommendations for us all for post-COVID patients. Next slide, please. So what have I learned? These are some of the things that misapprehensions I started out with. So I thought mild and moderate were all going to recover quickly. I think that's what we were all told, isn't it? That it was like a flu and people would get over it. But we know that 10% it goes on for more than 3 weeks, and 1 to 2% more than 3 months. And even the mild patients, even those patients with mild acute COVID, and possibly mostly the patients with mild acute COVID, can have particularly strange and prolonged and protracted symptoms. I used to think exercise was good for everything, but it definitely worsens those with post-exertional fatigue or malaise in this context. And it's potentially fatal in post-myocarditis. I used to think that, because I think we were told from Italy over here anyway, and working in the cardiology field, we were told they all get myocarditis. That's what's killing them in hospital if it isn't PE or if it isn't total organ collapse. And they're not all getting myocarditis. They're getting quite a range of conditions, as shown in that editorial, which, by the way, is out in November. And then, oh dear, do you have the concept of man flu over there? Oh, you do. Okay, so your husband's lying on the sofa with a flannel over his forehead, having in the middle of a cold, and he appears to be suffering a great deal. And, all the women, he's got man flu. So it does seem that our men are about twice as likely to get serious acute COVID and to die. And I don't know about, oh yes, I do know about the gender breakdown in post-COVID. It is probably 70% women. So, yeah, okay. If you survive it, you men, you're slightly less likely to get post-COVID. But I'm less inclined to joke about man flu now. Actually, I think it may be a real thing. I think I better stop there. Would anybody like to ask me any questions or just share your views?
Yeah, first I have to say, just thank you very much for a really good and interesting presentation. It feels like we're somewhat wiser now than in the spring. I was wondering one thing, and then we have some question from the chat, but did you look at the pre-existing conditions on all of these post-COVID patients? And how was it with that?
Yes, no. So according to that COVID symptom app, no relationship, no predictor. It's more an immune, well, I don't know. We don't know what it is, do we? But I mean, we know that pre-existing cardiovascular conditions, that is associated with a worse prognosis at the acute stage. But no, I believe there is no close relationship between post-COVID symptomatology and pre-morbid conditions.
Okay, because we had this debate in Sweden that you mentioned as well, that is this only psychosomatic or is it real and everything? But then it sounds in you like there is no correlation there. Yeah.
And I'm ashamed to say that one of the most convincing things for me is when my neighbours and my friends develop it. And, you know, I don't know what is the mindset going on in your average medic, but, you know, I have two neighbours with post-COVID. They are super vigorous, happy, privileged, you know, people with fulfilling jobs. You know, then they're not who you would expect to get a malingering disorder. On the low, there is yet another Twitter group, which is COVID in medics. And so I forget how many belong to that, but amongst them, there are some really prominent people, including academics. I wouldn't have predicted it.
Yeah, we have the same groups in Sweden and medic groups as well, and so absolutely. I guess we had some question from the chat as well, Karin, or I think it was David Gyll. Do you want to ask your own question?
I suggest David and Minna take their own questions.
Yeah, I didn't really have a question, but I was just reflecting on that. I think we're mixing like apples and oranges a bit, because you're talking about a 1% of people with long COVID experience symptoms beyond 12 weeks. But here in Sweden, we have a group of 40,000 people reporting COVID over 10 weeks. And it's clear from that numbers that there's also a large portion of people that are reporting these symptoms, but has probably not had a COVID infection. And then I wonder if it can be a negative effect if we say that their fatigue is caused by a virus, instead of talking about other fatigue functions and ways that fatigue can prolong, so that it can be bad for the patient to blame it on a virus which they can't affect in their own.
That's a really good point. And we all know you cannot separate mind and matter.
Anna sin mikrofon på nu, hörni.
Ja, jättebra.
Lars Bäcklund, kan du stänga av telefonen, tack?
Så att de har läst igenom.
De har fått order om det. Jag hoppas de har gjort det.
Lars Bäcklund!
Kasp och Trishas frågelista, det var de ofta inte läste liksom.
So now I can continue. I muted Lars.
Are we okay? Yeah. So we need to do both, don't we? Acknowledge that, well, if we think there's good evidence for it, and you know, if they have a classic thing in March and they've had the symptoms relapsing and remitting since then, we acknowledge the condition, but then we absolutely identify the things that could prolong or cause secondary depression. Yeah, I mean, our GP training is absolutely coming to the fore there as well, I believe. And yeah,
I'm just afraid that we're falling into the XMRV virus trap again, that when they were blaming ME on a virus, that it can be, it doesn't catch the whole picture, because it's evident from the narrative and the patient stories that there's so much more that affects these symptoms. And they share a very similar story of how they got sick and how the symptoms have been, but there's nothing instead in their diseases or in the lab or in anything else that we find a correlation. And this shouldn't surprise us, because there's rarely a strong correlation between fatigue and different diseases. And this is well known from before. I'm thinking a lot about Simon Wesley's great book about fatigue, when he talks about this, that there's rarely a good correlation between any disease and the level of fatigue. And fatigue is rarely best understood as a biomedical concept.
With very disabling effects, though.
And it can be.
I think it's really good to hear the skeptic's view. It's really hard to counter, actually. I just think we have to hold both viewpoints. We know for sure that your attitudes and your personal resources and the things around you influence how you react to an illness. I wouldn't ever deny that. It really does seem that there is something driving this as well, and that a constructive approach can help people out of it. I mean, I absolutely agree that we should not be nihilistic and sort of pacifist about it, you know, and just say, well, that's how it is, you know, and you're going to be exhausted for months, you're probably never going to, you know, it's that would make anyone depressed and wouldn't help. But if we just say, yeah, you've got this, but it really does appear that if you take things very slowly, think positively, plan your life accordingly, eat well, be aware of negative influences in your life, that you will come out of this. You know, you are not going to end up in a wheelchair, and you're not going to end up unemployable. That has to be the way forward, and it will be true in the vast majority. Can I ask for my last slide and move on to the next one, just because there's a couple of quotes here that might help us. Is that easy or not? Can we go back? Right, next one.
Next one. Yes.
Next one.
Yes, please.
Okay, so this is right. Okay, so he's seen 1,500 post-hospitalized, and he says the majority are going to get better slowly by pacing themselves with support from their primary care team and peers. You know, a few will need specialist input. So we needn't be full of doom and gloom. The majority of these patients will get better, probably whatever we do. But at least we can retain a relationship with the ones who have the genuine disorder by acknowledging it, and pick up on the ones who are not getting better for whatever complex reasons those are, be they physical or, you know, the sorts of factors you're thinking about. And those we need to refer. Prof. Trisha Greenhalg said, I think the medical profession need a new word to say to people with long COVID. It would mean, I believe you, I witness suffering, I share my uncertainty with you. I can't cure you, but I will not abandon you. That's, you know, quite powerful stuff, really.
Okay, I think that would be the nice and good last words, and we thank you a lot for your presentation and your wise thoughts. And I think that now we have your presentation and we can share it to everyone that was participating in this webinar, and we will also put it on our website if that's okay with you.
Please do, yes. I finished up with the last thing that about anosmia, because it's just such a weird symptom, isn't it? And actually it was reflecting on one of your participants' points about how common it is as a symptom anyway. Unbelievably common, according to this BMJ article that I've referenced. It might be the next slide. So the trouble with these symptoms is that are described is it's like a day in the surgery, isn't it? Every single symptom is one we're seeing every day, and if you took it to a logical, you would have to say that COVID-19 is there in the differential diagnosis of everything, which feels a bit ridiculous. But I think that's particularly the case. I know I've got a bit of tunnel vision when it comes to anyone mentioning anosmia at the moment. And it's important to recognize, there was a lot of it about before COVID. That's the only reason that's there, though. But you're very welcome to use the whole presentation for any purpose. And
okay.
Matthew Knight has said, by all means, share, if it's useful to you.
Yeah. Okay, but then we'll say thank you and end the webinar. And for those that are interested, we will have another webinar at 16 to 17 this afternoon. Ulf, do you want to say anything more about that?
Yeah, I only say welcome.
Oh, thank you. And thank you for welcoming me. And I would so much love to ask you about your experience, but another time, another context maybe.
Yeah.
And from chat, we have a few questions that I think we will have to leave because of the time is running out. Question.
As you wish. You can email them to me if you like.
Yeah.
If that helps.
Yeah, we can try and email the questions that are left. And of course, it would be best to discuss them. But since the time is short now, we will collect them and mail them and maybe publish them on the website.
Yes, that's good.
As you wish.
Okay.
Okay.
Thank you very much, everyone.
Pleasure. Thank you for asking me.
Thank you, Christine. Bye.
Okay. Bye.
Bye-bye.